Hello, good evening, everyone, and welcome to the ICS Sleep Certification course. And today is another series and a very important topic. Whenever we talk about sleep disordered breathing, pulmonologists would want to emphasize always on obstructive sleep apnea. There is much more to sleep disordered breathing than obstructive sleep apnea, and people who do a lot of work in sleep would realize that a lot of our practice is actually, centered around other sleep disorders, obesity, hypoventilation, central sleep apneas, mixed sleep apneas, upper airway resistance syndromes, which we are picking up quite often these days. So, rightfully so, we have a very interesting talk today, followed by a panel discussion, as is the general order in these ICS meetings. For the same, I'd like to thank the organizers, Samaria sir, Amita Nene ma'am, and Rajadhar sir for doing such a stellar job. Hitesh and the technical team support from CIPLA for helping us every time. You guys are great support. And today the pattern would be that we'll have a talk on these lesser recognized but equally important sleep disordered breathing syndromes first, and then we'll have a panel discussion. So we have a stellar panel today, people who are top of their games, and I'll be introducing them as we start the panel discussion. But first we'll have a 20-minute talk by none other than Dr. Mahavir Modi. Mahavir is a senior pulmonologist based out of Pune. He's been associated with the legendary Ruby Hall Clinic for the last 22 years plus. Does a lot of stellar work with allergies. I'm a big fan of what he does with his allergy, and it is always such a pleasure interacting with you, Mahavir. So Mahavir has multiple feathers, laurels to his cap. He has won multiple awards, including the Bharat Ratna Indira Gandhi Gold Medal Award. And he has been trained by Professor Gasparini in interventional pulmonology. He's trained at Italy. So, and then, on top of this, a wonderful person to interact with and a great friend. Mahavir, thank you so much for being a part of this today. And the stage is all yours. We'll introduce the rest of the faculty as we take the panel discussion. We'll take it that time. But all yours, Mahavir, for your talk.
Thank you. Thank you so much. Thank you, Dr. Arjun, for those kind words. And thank you, Dr. Amita, Dr. Raja, and Team ICS. So I will just start with the presentation. Is it visible? Yeah. So we are going to talk about this, as Arjun said, that the lesser diagnosed but more, something which is required is UARS, obesity hyperventilation syndrome, and then the central sleep apnea. Of course, we are just going to do an overview because each one of them is a topic by itself to discuss upon for hours together. So when we talk about the sleep disorder breathing, we know that there are different extremities, like maybe starting from snoring, and then we have this upper airway resistance syndrome. Then we have obstructive sleep apnea, which we are not going to talk today. And in previous modules, we have discussed them in great details. And then we have obesity hyperventilation syndrome. And then we have variety of central sleep apnea along with its subtypes. So the first topic is about the upper airway resistance syndrome. So this is something which is very important because it is frequently missed in our clinical practice because we are not doing level 2 or level 1 sleep scoring. And in our home sleep apnea test, many times we miss upper airway resistance syndrome. So what is it actually? So as the name implies, it is basically an airflow limitation because of which there will be due to increased respiratory efforts. Maybe many patients, they have the anatomical variant in the upper airway, so they have to breathe heavily and at night, and because of which there will be airflow limitation. This airflow limitation causes arousals from the sleep, because of which there is frequent fragmentation of the sleep and the patient have daytime symptoms. But what is important to know, and how do you differentiate it from your sleep apnea, is that there are no desaturations involved in upper airway resistance syndrome. So this is also called as RERA, which is respiratory effort related arousals. If you ask me to define this as per the polysomnography, so these patients will have typical AHI, which is less than 5 events per hour, as compared to your sleep apnea, where you have the AHI index of more than 5 events per hour. Saturation, these patients, they won't have desaturation, so oxygen levels will be mostly more than 92%. And if you see the flow limitation on the PSG channel. So out of the total sleep time, almost 5% of the sleep time, these patients, they will have flow limitation. And this RERA, that is a respiratory effort related arousal index, it is more than 5 per hour. And of course, along with all of this, these patients, they have daytime symptoms. So that is how a UARS is actually defined based upon the clinical as well as on the polysomnographic guidelines. So why there is increased resistance in the upper airways? It is more of a ENT domain, but we know that there are a lot of patients, those who have increased resistance in the retropalatal or in the retroglossal area. And in susceptible individuals who has narrow airways, and along with that, there are certain individuals, they have more collapsible airways, and there is this concept which is called as a critical pressure, which we are not going to talk in details. And there is one more phenotype of this sleep apnea, which is a low arousal threshold. So in a susceptible individual who has a narrow airway plus lower arousal threshold, and those who have more upper airway collapsibility, so all these patients, they are basically predisposed to this upper airway resistance syndrome. And how common it is? Of course, it is very common, almost 3 to 4%. And if you see, as compared to obstructive sleep apnea, which is 24% in men and 9% in women, mild OSA, as compared to that, UARS is more common in women. So around 4.4% in women and 1.5% in men. So it is basically common in perimenopausal women. So that is something which we have to remember, and more as compared to males. The clinical features, of course, they will present similar to that of obstructive sleep apnea. They will have snoring, they have excessive daytime sleepiness, daytime fatigue, they may have daytime arousals, and these arousals, they may be sleep disruptions and fragmented sleep, and so they don't get wake up in the morning fresh. One way to differentiate them from obstructive sleep apnea is that the partner will never give history of witnessed apneas or gasping at night, which is typically sometimes which is seen in patients with OSA. So how do we diagnose? Of course, as I said, that if you are doing a home sleep apnea testing, you will underestimate this because you won't be able to know the EEG arousals as well as the flow limitations. So a full PhD is required, because full PhD will be able to give us about the EEG arousal as well as the flow limitation. So this is just one graphical presentation that if you see on the flow channel, you are able to see that there are some peaks, but at majority of the times, there is a flow limitation in all of the in this nasal sensor, flow sensor. Along with this, there is no desaturation. If you see the oxygen levels, it is continuously same oxygen saturation, so there is no desaturation. But if you see the EEG waves in the alpha waves, in the occipital lead, you can see the alpha waves. So that means there is a EEG arousal which is happening because of flow limitation in the absence of desaturation. So that is how a typical UARS will be seen on your polysomnography. So how do you treat these patients? As I said, that it is more of an ENT domain. So you have to first find out if there are any anatomical problems such as nasal allergies, dental malocclusions, and abnormal lifestyles that you have to correct. CPAP titration in the sleep laboratory can definitely will be able to much more beneficial as compared to giving an auto CPAP titrating device, because you need to adjust each and every flow limitations which are happening at night. You can use sometimes oral appliances, and there is some role of hypnotics, especially the patient has low arousal threshold, but that is something which is yet to be proven for these kind of patients. So this is about, in short, about the upper airway resistance syndrome. Then we'll move quickly to the next topic, which is our obesity hypoventilation syndrome. So I think as a pulmonologist, this topic is very, very important, because we often come across these kind of patients in our critical care scenario. And that will be the first time when a patient of OHS may be coming to you, and unless you diagnose, these patients will remain undiagnosed. And that's the reason that many of these patients have very, very delayed kind of presentation, delayed kind of diagnosis. So how do you define? So these patients are obese, so they have body mass index which is more than 30. Then they have sleep disordered breathing, and which are different sleep disordered breathing in OHS, that is the different phenotypes which will just come in our subsequent slides. And these patients have daytime hypercarbia. That means their carbon dioxide level in the daytime is more than 45. And of course, we have to exclude all other causes which can cause this daytime hypercarbia, like neuromuscular causes, mechanical causes, or metabolic causes which can cause daytime hypercapnia. So which are different kind of sleep disorder breathing which can be seen in obesity hypoventilation syndrome. So although the term hypoventilation, it is not always hypoventilation which is happening in these patients. And this has to be very clearly understood that almost 90% of patients with obesity hypoventilation syndrome, they will just have pure obstructive sleep apnea, and they may not have much of hypoventilation. So this is very, very important for us to understand. So these patients will have AHI of more than 5, and almost 70% of these patients, they may have very severe kind of obstructive sleep apnea with AHI of more than 30. So after saying this, these 90% patients, but there may be around 10% of patients where they may not have obstructive sleep apnea, but they may have predominant only hypoventilation in these patients. And how do we define hypoventilation in these patients? Is if they have carbon dioxide at night, which is more than 55 millimeters of mercury remaining for more than 10 minutes, or they have nighttime carbon dioxide, which is more than 10 millimeters of mercury as compared to their daytime carbon dioxide. And of course, the level should be more than 50 millimeters of mercury at any given point of time. So that is how an hypoventilation is defined in remaining 10% of these patients of OHS, where they don't have predominantly sleep apnea, but they have hypoventilation. So how common is obesity hypoventilation syndrome? Of course, obesity is becoming more and more common. Patient those who are overweight, maybe 1 in 3. Patient those who are obese with BMI of more than 30, 1 in 10. Those who have severe obesity, BMI of more than 40, they are 1 in 30. And those who have BMI of more than 50, almost 1 in 230. So there was this one particular calculation paper where it was shown that almost 7.5% of the adult US population, they are morbidly obese with BMI of more than 40. So once we have this obesity epidemic, definitely the incidence of obesity hypoventilation syndrome is going to increase. And as a pulmonologist, we should not miss these cases. So men and women are again equally affected as compared to OSA, where men are predominantly affected. So women also will be cases of obesity hypoventilation syndrome. As I said, most of the times the presentation is delayed and the patients may present to you in crisis with type 2 respiratory failure in the ICU. Almost 75% of OHS will present in this way. Many of the patients, they can be misdiagnosed as COPD. By you and me being a pulmonologist, we should not be missing these cases to label them as OHS. So what happens is a typical OHS patient, he comes to the casualty, then he is diagnosed as having type 2 respiratory failure. You put these patients, then diagnose them as OHS, and you put these patients on maybe some kind of positive airway pressure therapy. Once you put these patients on PAP therapy, what this diagram shows that the patient's hypoventilation as well as the pulmonary hypertension, it will keep on declining as the patient is intervened by nocturnal PAP therapy. But these patients, they have a lot of comorbid metabolic conditions like diabetes mellitus, heart diseases, and unless you are having a lifestyle modification in these patients with weight reduction and other kind of therapies, then their morbidity and mortality because of these comorbidities won't decrease unless you intervene by some other kind of measure. So this is something which is very important. So it needs a multidisciplinary treatment in managing these OSA kind of patients. So is it like each and every obese patient, they will have OHS? Of course, no, and there has to be some screening test. This is again very important, that how do we screen these obese patients for OHS? So there is a serum venous bicarb level. So if you're doing a venous bicarb level and if it is less than 27, 97% of your OHS can be excluded. If your patients have venous bicarb level which is more than 27, then you have to ask them for ABG to look for the daytime hypercapnia. Also, if these patients, they have hypoxemia with in males, saturation level being less than 95, and in females, saturation level less than 93%. Along with that, if they have low FVC, again order an ABG and see for if these patients have daytime hypercapnia. So daytime hypercapnia of CO2 level of more than 45 is diagnostic in these obese patients for OHS, and you have to take help of these bicarbonate levels, which can be used as screening tool, and also the saturation levels. So is it possible for all the time to look for the PSCO2? Of course not, especially because when you want to define hypoventilation as nighttime CO2 level of more than 55 for more than 10 minutes, so you can use certain other kind of measures, especially you can use a transcutaneous carbon dioxide monitoring, which is done in the level 1 sleep lab in majority of the centers. There is one device which is called Tosca, which is available, which can be used even in the daycare unit, where you can just put it on an ear probe and see the patient's carbon dioxide levels. Of course, you can have other measures like end-tidal carbon dioxide, you can do venous blood gases and venous carbon dioxide, and sometimes you can be able to do arterialized capillary blood gases to know the level of PSCO2. So these are all can be surrogate markers for PSCO2, but daytime ABG is ideal, where PSCO2 level of more than 45 will be able to diagnose these patients. So is it that each and every OHS patient, they are same? So as I said, that majority of the patients of OHS, they will have isolated severe obstructive sleep apnea. Then there is a second category of patients which we discussed, that these patients, they won't have much of sleep apnea, but they will have predominantly isolated obesity hypoventilation, where hypoventilation occurs more commonly than the sleep apnea. And then of course there is a third variety where they will have combined. So they will have hypoventilation along with sleep apnea in these patients. So it is, as a pulmonologist, we want to find out whether your patient is into which group, and accordingly we will be able to treat these patients. So obesity related changes, of course, obesity causes decrease in the diaphragmatic movement. There is microatelectasis, there is increased airway resistance. All of this basically causes a lot of increased work of breathing in these patients. So especially at nights, if this patient at night, this patient will have increased work of breathing. So for this increased work of breathing, there will be more demand on the respiratory drive. So patient will have more respiratory drive. And what happens is, because of this more respiratory drive, and suppose if the patient is not able to maintain this particular respiratory drive, the patient will start building carbon dioxide. And especially in the REM sleep, where diaphragm is the only muscle which is active, and in your obese patients where diaphragm functioning is not good, so these patients, they will start accumulating CO2 in their REM sleep, and this keeps on happening throughout the REM sleep repetitively, and then it causes its overpercussions and the secondary depression of the respiratory centers, leading to daytime hypercapnia and the obesity hypoventilation syndrome. So we don't know why in REM sleep it basically happens, but there is one theory that maybe there is overproduction of this leptin, and this leptin has resistance in the obesity patients, and because of this leptin resistance, that can cause central hypoventilation in these patients of obesity hypoventilation syndrome. So these are two different mechanisms. One is a sleep apnea, which is common because of excess of fat, microatelectasis, increased pharyngeal collapsibility, that is causing sleep apnea. And the another mechanism is because of the hypoventilation, where these patients are more predominantly predisposed to developing REM kind of hypoventilation in these patients. So these are two different phenotypes in these patients. So how do you treat these patients? Suppose you have a patient who has only predominantly obstructive sleep apnea, then you have to treat these patients by giving a CPAP therapy, and these patients, they won't require NIV. But if you have a patient who has obesity hypoventilation syndrome, then along with opening of their airway by using EPAP, you should be able to give them IPAP, because the IPAP will be able to increase their alveolar ventilation and improving the overnight gas exchange, and that is how you can treat these patients hypoventilation. So if the studies have also shown that in NIV also, if you have a control rate, then these patients will be able to have better daytime symptoms as well as the improved quality of gas exchange which is happening at night. And that's the reason that if you're using NIV in these patients, especially in the hypoventilation category or the mixed category of OHS patients, you should always use a machine which has a backup rate. So backup rate is mandatory for these patients to ventilate for ventilating the hypoventilation patients. So to cut short, if you have obesity hypoventilation syndrome, and if you have their AHI, apnea hypopnea index, which is more than 30, so that means patient has predominantly severe OSA component of OHS or this kind of phenotype, and these patients, they should be given CPAP and not NIV. Okay, and if there is a CPAP failure, then you have to consider giving NIV in these patients. And in the minority of patients of OHS, where the AHI is less than 30, that means they don't have much of sleep apnea, they have more of hypoventilation, and then these patients should be given NIV, and this NIV can also be weaned off after a period of 3 to 6 months. And many of these patients, those who initially require NIV, they can be still managed with your CPAP. So this is the bottom line, that not all patients with OHS, they will require NIV. They can be converted back to CPAP. Always wait up to 6 weeks before immediately shifting the patient to NIV. All your AHI, CO2 as well as the ODI all can improve over 6 weeks of period of time. There is another mode which can be used, and I think we will be discussing more in the panel discussion, that is AVAPs or IVAPs, where you can ensure the adequate tidal volume in all stages and in all positions of the sleep, so that you can give adequate tidal volume so as to improve these patients' gas exchange as well as daytime symptoms in patients with OHS. So this is, I think, something which I can share with all of you, but we won't go in the details of this. And then about the last part of my talk, that is about the central sleep apnea. So central sleep apnea is something which is very important. And although most of our textbooks, they discuss about the obstructive sleep apnea, CSA needs a special mention, especially because the sleep being a subspecialty is developed under the heading of our pulmonology. So what is CSA? There are recurrent episodes of cessation or reduction in the airflow, and they are happening in the absence of respiratory effort. So in obstructive sleep apnea, there will be cessation or reduction in the airflow, but the patient will have continuously respiratory effort. But when there is a centrally respiratory effort is absent, then these patients, they can be labeled as central sleep apnea. Again, it is more common in the males as compared to the other two diseases, UARS and OHS, which are equally common in females. Okay, and this is more common in the older age group. As per the sleep heart health study, OSA was seen in one category of patients was 47%, whereas CSA was only 0.9%. So we should not be giving overemphasis on CSA, but we have to always think that our patients should be treated for OSA component as well. There can be physiological central sleep apnea also, which can happen during the sleep onset, and sometimes just after the arousal also the physiological central sleep apneas can happen. There are two different classifications of central sleep apnea. This is the ICSD classification, which we won't go in the detail, but this is another classification which is more practical. And there are classical two kinds of the central sleep apnea. We can say hypercapnic central sleep apnea and hypocapnic or non-hypercapnic kind of central sleep apnea. So non-hypercapnic or hypocapnic central sleep apnea is something which is very commonly seen, especially in patients those who have heart failure, because these patients, they may have typical crescendo decrescendo pattern like the Kind-Stokes breathing. Then this patient, there can be idiopathic central sleep apnea. There can be high altitude central sleep apnea. Then there can be treatment emergent central sleep apnea, which is called TEXA, and then the primary central sleep apnea. So they are all patients where your CO2 levels won't rise. And on the other hand, we have hypercapnic kind of central sleep apnea, where your lungs or your neuromuscular system is at the fault. So the patient, those who have neuromuscular diseases, COPD, chest wall deformity, obesity, hypoventilation syndrome, brainstem pathology, or the patient, those who are on opioid use because of their terminal malignancy, they all can have hypercapnic kind of central sleep apnea. So pathophysiology of central sleep apnea is quite it's a physiology chapter, and it will be a great discussion, but we don't have that much of time to go through it. But I can just say that there are two different types, that's the hypercapnic and this hypocapnic. So hypocapnic are something where you have increased loop gain, and loop gain is something, when the patient has heightened chemoreceptor sensitivity. So a small stimulus or small increase in the carbon dioxide or decrease in the carbon dioxide will cause their respiratory center to have lot of variations. So that means their unstable ventilatory drive, and because of which the small level of their carbon dioxide increase, that will cause hyperventilation. Because of hyperventilation, there will be CO2 washout. If the CO2 goes below the apnea threshold, then the patient will have central apnea. And again, once the CO2 level goes down, goes rising, after this, the patient will have crescendo decrescendo kind of Kind-Stokes breathing. So this kind of cycle keeps on happening, and that is how your typical Kind-Stokes breathing central sleep apnea will happen. And in the patients where their the loop gain is normal, but if they have compromised lung condition, then these patients will have typical hypercapnic kind of central sleep apnea. So, there is this feedback loop, and this kind of mechanism is there where you have visualize the respiratory system as a closed feedback loop. Okay, and if you have three different components, for example, you have a controller which is in your brain, which has pons and medulla and which have chemoreceptors. Then the plant, which has the lungs through which your oxygen carbon dioxide exchange is going to take place. And then there is a circulation, which is a mixing, from where the circulation time is going to decide which kind of central sleep apnea this patient is going to have. So there are three different components for this the loop gain to understand. So loop gain is something, as I said, that if the patient has high loop gain, then they are going to have this hypocapnic kind of central sleep apnea, and this is something which is seen in patients those who have central sleep apnea because of heart failure or because of high altitude or because of stroke or renal failure. And if the patient has normal loop gain but they have increased control plant gain, like their lungs are at then they will have different kind of central sleep apnea. These are hypercapnic kind of sleep apnea. I know it is difficult, but you all have to understand that these are different types and they there are different kinds of treatment available for these patients. Clinical features, these patients, they will be presenting similar to your obstructive sleep apnea with same kind of clinical features. And diagnosis is basically based upon your polysomnography, where you will have more than 90% drop in their flow, and which will be remaining for more than 10 seconds, to call it as a apnea, and it will be in the absence of respiratory effort. So if you have AHI of more than 5, and if the central apnea events are corresponding to more than 50% of the total respiratory events, then you call them as central sleep apnea diagnosis. This is one particular pictorial presentation where it is typical crescendo decrescendo kind of pattern interfering with the central apnea. So the central apneas are the one which are shown by the black arrow. So there is no flow, and there is no effort also in the thoracic and the abdominal bed. So the central apnea followed by the crescendo decrescendo hyperventilation pattern. Again, there is a central apnea, and again there is a crescendo decrescendo kind of pattern. So this is typical, which is called as Kind-Stokes breathing. So there has to be 3 such events of central apneas followed by crescendo decrescendo breathing, and each cycle length. So the cycle length is calculated from the time of the initiation of your central apnea to the end of your crescendo decrescendo pattern. So each cycle length should be more than minimum 40 seconds. So if you have these criteria, then you will be able to diagnose this patient as Kind-Stokes breathing. This is one example of, if you see that this patient is put on CPAP of 18 centimeters of water, and after putting CPAP of 18 centimeters of water, suddenly there is an apnea in the absence of respiratory effort. So that means the patient is developing treatment emergent central sleep apnea. So that means maybe we are overcorrecting these patients by giving CPAP. This is one more kind of this central sleep apnea, where the patient has multiple central sleep apnea episodes, which are shown by these black arrows. And if you see the other breathing pattern, it is quite chaotic and the irregular rhythm. So this is typically seen in patients, those who have basically maybe a BIODS breathing or random apneas, and these kind of patients. So this is a Kind-Stokes breathing which is seen in patients with which is called as BIODS breathing. How do you manage central sleep apnea? The management of central sleep apnea is basically depending upon whether it is hypocapnic or hypercapnic. In hypocapnic, you have to treat their underlying cause, for example, heart failure. So to treat the heart failure, you can give diuretic, give ACE inhibitors, beta blockers, maintain the rhythm, those kind of things. If you have a patient who has central sleep apnea because of their increased plant gain, that means the respiratory system is at fault, then you can use BiPAP kind of device, and where you have to have a backup rate also, and then you can use drugs like acetazolamide in these patients. If you have a patient who has a basically because of the high loop gain kind of central sleep apnea, then you can use CPAP therapy in these patients. You can use modes like adaptive servo ventilation in certain category of patients. Supplemental oxygen also can be used. And if to stabilize the ventilation, you can use transvenous phrenic nerve stimulation, which is available. And we have to find out the cause. For example, if it is because of drugs like opioids or because of ticagrelor, so those kind of drugs needs to be avoided while managing the central sleep apnea patients. So again, in central sleep apnea, many of these patients, they can be just managed with your CPAP, and not everybody will require a higher kind of like ASV or BiPAP kind of device are not required for many of the patients. Just 1 or 2 slides about this new mode of ventilation, which is called adaptive servo ventilation. A lot of physicians, pulmonologists, they are jumping on use of this particular ASV mode, but it has to be understood that it is to be contraindicated in patients those who have heart failure with ejection fraction of less than 45%, and we have SERV-HF as well as ADVENT-HF trial. Both the trials have shown more mortality if you use HF ASV mode in patients those who have ejection fraction less than 45%. So if you have a patient with ejection fraction of 45%, you are adequately treating the heart failure. After that, also by using CPAP, if the patient's AHI is not coming down to less than 15, then only you can use this BiPAP ASV. If BiPAP ASV fails, then you can use BiPAP ST mode and then SOS oxygen therapy. On the other hand, if the patient is ejection fraction less than 45%, then never go and use your ASV mode. You can use CPAP. If CPAP fails, then you can use BiPAP ST mode and SOS oxygen therapy. A slide about treatment emergent central sleep apnea, which we discussed, that if the patient is on CPAP and the overuse of CPAP sometimes brings this central sleep apnea into picture, you have to be very patient. just keep on giving them same kind of CPAP for a period of 2 to 8 weeks, and almost 80% of these central sleep apneas will resolve with the use of adequate CPAP. If not, then you can use adaptive servo ventilation again if you have ejection fraction more than 45%. Opioid induced central sleep apnea, you can use BiPAP or you can use ASV or ST mode in these patients. So to summarize, I know I have rushed through some of the slides, but time is a constraint. So we have discussed about UARS as a definition, that these patients won't have desaturation and they will have AHI which is less than 5, but there will be flow limitations and frequent arousals. You have to have a PSG and not home sleep apnea test to diagnose this UARS. There are patients, those who have low arousal threshold and those who have narrow susceptible airways, they will have more chance of developing UARS. Clinical features will be same as compared to OHS, but there won't be frequent apneas or witnessed apneas in these patients. And then we can have surgical as well as non-surgical management, and a fixed CPAP in the laboratory is much more required as compared to auto CPAP, which we normally tend to give in our clinical practice. Then we discussed about the OHS, we discussed about the bicarb level and how do we use the screening test like oxygen levels, bicarb and FVC to diagnose these patients of OHS. We discussed 3 different phenotypes of predominant OSA, predominant hypoventilation and a mixed kind of patients. And then we don't have to jump on to use of the newer modes like AVAPs, because CPAP also can be used in majority of the patients, and NIV will be used only in hypoventilating 10% of the patients. We talked about central sleep apnea, different mechanisms, hypercapnic, hypocapnic, not to use ASV if ejection fraction is less than 45%, and then different drugs as well as the treatment emergent central sleep apnea. So all these things have been discussed in great details, but I think in the panel discussion we'll be like to answer this in much more depth. So thank you if I overshot the time. Sorry for the delay, but it was a huge topic. Thank you so much.
Thanks, Mahavir. I absolutely understand. These 3 topics in themselves can be an individual talk.
Thank you.
So thanks for summarizing it so well. We'll take it forward in the discussion. So can I please ask the organizers to put up the slides of the panel, please, so that I can introduce them and we can go ahead with the panel discussion. So Hitesh, if you can please put up the slides of the panel. Yeah. All right. So, as I said before, these 3 topics that we have discussed today, pulmonologists need to understand this more because we do see this as commonly as we see sleep apnea. And Mahavir, of course, would be a part of the panel discussion we have today. Then joining us today is Dr. Bindu CG. Madam is a pulmonologist and associate professor in pulmonary medicine at the government. Slide, Hitesh.
Not able to listen to Arjun. Yeah. Okay. Yeah. Yeah, okay. So we have Dr. Bindu, who's the MD
Yeah.
Pulmonary Medicine. Yeah, Arjun, you're back. And she's associate professor.
Yeah, I'm back.
Okay, yeah, please start.
So the next slide, please. So joining us is Dr. Unnati Desai. Dr. Unnati is again a pulmonologist, and she's a pass out of Mumbai. And she's done her fellowship in interventional pulmonology from Mumbai. Madam is the additional professor and in charge of pulmonary medicine at BYL in TNMC Mumbai. Multiple presentations, multiple fellowships to her credit. Thank you, Unnati ma'am, for being with us here today. Next slide, please. Then we, of course, have Swapnil. Swapnil is a dear friend, and Swapnil hails from Pune. Swapnil is attached from KEM Pune. And apart from being a pulmonologist, Swapnil dons multiple hats. He's a biker, drummer, and a guitarist. And always good to interact with you, brother. Thanks for being here with us today. Thanks, Swapnil. And one more, yeah. So yeah, thanks, of course. So the youngest, of course, Prajay from Mumbai. Thank you, Prajay, for being with us here today. And Prajay is, of course, an active member of the Indian Chess Society and is joint secretary of the Jogeshwari Medical Association. He's associate with Holy Spirit Hospital, Criticare Asia Hospital, and Bhartiya Arogya Nidhi Hospital. His areas of interest are asthma, ILD, and interventions. Thank you, Prajay, for being with us here today. All right. So as this is over, I go to the most important part of today's discussion.
Before that, I would like to introduce Dr. Arjun.
Yeah.
Can I have his slide, please? Dr. Arjun needs no introduction, literally. He is like Virat Kohli of pulmonology. He is presently head of the department and senior consultant pulmonary medicine at Amrita School of Medicine, Faridabad. He is a PSR fellow. He worked as an assistant professor at AIMS, New Delhi. He has been awarded as Global Rising Star in Pulmonary Medicine in 2019 at Lung Health Council Nice, France. He has more than 100 publications, and his areas of interest are severe asthma and airway diseases, pulmonary rehab, and end-of-life care and palliation. Thank you,
Thanks,
Dr.
Yeah, thank you. So going to the discussion, we've already started getting a lot of questions, and I'll try to summarize it, as succinctly as possible. So I request the panelists to be brief with their answers. So I'll start with Bindu, ma'am. Ma'am, upper airway resistance syndrome. Mahavir very rightly said that mostly, ENT kind of a domain, but as pulmonologists, we do see it every now and then. So what are your, pickup points for upper airway resistance syndrome? What age group should we be suspecting it? And how should we suspect it at all?
Thank you so much. ICS and Dr. Arjun. It's a sleep-related breathing disorder where during sleep, there is increased resistance to the airflow and whereby you have a disturbed sleep and as a result, you have daytime symptoms. But here what is very prominent is the RARAS, that is the respiratory effort-related arousals, which are seen. And it's a mild form of OSA, but here you don't see apneas as such. You don't see apneas, you don't see desaturation also much. So there are a few definitions which are coming in. That is, one is the American Sleep Disorder Association has come up with a definition where the apnea HI index is less than 5 per hour and RARAS more than 10 seconds or arousal index more than 10 per hour. Another one is by definition, which is where the RARAS are seen in polysomnography, which is associated with daytime symptoms. And the 4 criteria that are given us: AHI less than 5, the saturation is more than 92, and the presence of airflow limitation during sleep more than 5% of the total sleep time, with daytime symptoms of fatigue or increased sleep. And now coming to the second part, it is seen in adults mainly, but it is not picked up. The symptoms are mild, so it is usually not picked up. So the prevalence is probably more. And the prevalence which is seen in epidemiological studies it's seen more in females, 4.4%, and in males it's around 1.5. And an epidemiological, Sao Paulo epidemiological study, an interesting study actually, it was done in children with attention deficit hyperreactivity disorder. And those children, when this polysomnography was done, it picked up upper airway resistance syndrome in around 50% of the children. And when they were given treatment and surgical correction was done, the symptoms of attention deficit hyperreactivity syndrome disorder came down. So it may manifest in a different way, like in the adults, it may manifest hypersomnia, etc. So it needs to be picked up more, and the incidence or the prevalence rate is usually around 10 to 15%. And in those with snoring, in patients who have undergone polysomnography, 10.5 is the prevalence of upper airway respiratory syndrome. So it is common, but we do need to pick it up more.
All right. Thanks for that. So Swapnil ma'am has tried to sum up, the epidemiology of it. When do you suspect it? Does it sound like someone who has symptoms of sleep apnea, but you do a sleep study and the criteria of sleep apnea are not being met? Is that what upper airway resistance syndrome is? When should a pulmonologist suspect it in the OPD? What are the clinical features that should point towards it?
Yes, sure. So the symptoms and the clinical features are quite similar to that of OSA. It is as but Madam said, and we Mahavir sir said, it is more common in females and lean and thin individuals as compared to OSA, which is commonly seen with male adults who are obese. Symptoms are quite similar to that of OSA. That is, patient will have excessive daytime sleepiness, fatigue despite of normal sleep duration. Insomnia or sleep maintenance difficulty is one thing which might arouse the suspicion of this UARS. Morning headaches, then cognitive issues like mood disturbances, frequent awakenings, non-restorative sleeps are some features which are seen with UARS. It lies on the spectrum between primary snoring and obstructive sleep apnea. So here on the basis of sleep study, when we get AHI, which is less than 5, but with the symptoms of suggestive of sleep apnea, then it is likely UARS.
Sure, very rightly said. And talking more about the pathophysiology, Unnati ma'am, so why is it more common in thin and lean individuals, more common in females? What sets it apart from the classical sleep apnea that we see in the obese people? So what's the pathophysiology behind upper airway resistance syndrome?
Okay, so as we know, as the name suggests, it is a resistant upper airway. It's an upper airway resistance syndrome. So there are multiple factors which gives rise to this resistance in the upper airway. These factors could be, structural, anatomical factors. These factors could be, neurological factors. These factors could be hormonal factors, which just give rise to a upper airway, which is resistant and which causes which causes an increased airflow limitation and the arousals. That's simply put it. It's also known as a variant of OSA.
Absolutely, ma'am. So nicely put, and you've summed it that so well. Any hormonal link there? Why do we see it more commonly in females, and that too in lean females? Is there any connection with hormones there, or why is it so common in females?
Correct. So the female hormones basically have a linkage associated with these, your UARS.
Sure, and it's one of the most difficult sleep disorders to treat, because these females typically would not be tolerant to the CPAP device. Very, very difficult, actually, clinical condition to treat. And they would keep coming to you with these vague symptoms, body aches, lethargy, not feeling well. A lot of them would be diagnosed as having anxiety, depression, and a difficult, clinical situation to treat. So, Prajay, just to sum it up, there are a lot of youngsters here today who are probably new at interpreting the sleep studies. How does one interpret the sleep study of someone with suspected UARS? What are 1, 2, 3 bullets that you want to give us for interpreting the sleep study of someone with UARS?
Before I give my answer, I would like to thank you for excellent moderating, which you are doing it. Excellent talk by Modi sir. And thanks to Amita Nene madam, the team ICS for inviting us. So as you said, for all the juniors who are new in the practice, first thing is, if you want to diagnose UARS, you have to get a level 1 or a level 2 sleep study, because it has an EEG, which is important to find out whether there is an arousal there or not there. Because level 3 or level 4, they are mainly used to diagnose your apneas and hypopneas, to diagnose mainly for your OSA patients. So if you see a level 1 or a level 2 polysomnography, so there are 3 things to differentiate apnea from hypopnea and RERAs. For apnea, there has to be a complete cessation of the airflow limitation for a minimum period of 10 seconds or more, with or without desaturation. For hypopnea, there has to be a significant reduction in the airflow limitation, more than 30%, associated with a desaturation of 3 or 4% of the saturation of the oxygen. When out of this, if they do not meet the criteria, there is a limitation in the airflow, but without any desaturation, and along with an associated arousal, which you can see on the EEG, then you diagnose this as a RERA, which is the symptom of which is the sign of your UARS, which, as Modi sir has already said, if the score of RERA is more than 5 per hour, it is classified with the diagnosis of UARS, and the saturation has to be more than 92%.
Sure, very well said. And the most important message that needs to be put across here is that for someone with suspected UARS, you don't do home-based sleep studies. So home-based sleep studies are only meant for patients where there is a classic sleep apnea which is suspected. The patient does not have too many comorbidities, where milder sleep disorders are not being suggested. And a huge problem with Indian studies or sleep practice is that majority of the sleep studies, at least in the part of the country where I practice, the home-based sleep studies are actually cheaper. So a lot of people would want to get these done. So you would actually never see UARS or RERAs coming up in a home-based sleep study. So Prajay, a very important point that you've put forward is, to pick this up, you need a in-house, in-lab, attended full polysomnography by a technician who is certified, who understands what he's looking for. Because even in-lab studies, a lot of times we see that UARS, these RERAs are not picked up simply because the technicians who are doing it are not trained enough to pick up the RERAs. So you would have a sleep study which comes out as, a normal sleep study, and you're still perplexed because this patient has symptoms which are suggestive of classic sleep apnea, but somewhat not there, right? So you need to suspect it. The technician needs to be trained, and then you need to do an in-house sleep study, and that is how you'll be able to pick it up. Now, that's the easy part of doing it. The most difficult part of treating the upper airway resistance syndrome is actually the treatment part, because whatever practice, I hail from a department, I'm from Sabdajang, so we sleep is a part of our DNA. And the students, the residents that were not liked by people were given thesis on UARS. So that's how bad it is. So Mahavir, how do you treat this mystery?
Yeah, so actually, I mean, majority of these patients, they will have, as I said, that it's a more of a ENT domain. So many of these patients, they may have some nasal allergies, or they may have deviated nasal septum, or there may be some upper airway disorder, which is actually causing more narrowing of the airways, and that is the reason that they will have increased resistance to go through, for the air to go through. So first is definitely to treat these nasal allergies by using maybe some kind of nasal sprays, intranasal corticosteroids, and ENT opinion is very well required in these patients, because we need a multidisciplinary kind of treatment. So ENT becomes a part and parcel of these kind of patients. So of course, take an opinion from the ENT as far as possible. Lifestyle modification, weight loss, so those therapies also definitely help, because that will again increase their space inside. There are some category of patients, those who have maybe mild OSA, or they may have UARS. So these patients, they can be managed with a mandibular advancement kind of device. So these are the devices which can just have the jaw getting pushed forward, your tongue getting pushed forward, and that will create some space behind in the retropalatal area, in the retroglossal area, and that is how these patients, they can be treated with. And there are a lot of companies nowadays, where you can have these customized, as well as some kind of devices are available, and these can be adjusted around 0.5 millimeters. Lower jaw can be moved forward as compared to the upper jaw, and it can increase the space. Even the position therapy, asks the patient to lie down on the one side as much as possible. So those kind of therapies also can be used. And of course, if the patient is have anatomical factors, they are corrected, and still the patient is symptomatic, then CPAP remains the treatment in these patients. And again, in these patients, because we want to know how much the flow limitation has been abolished by your CPAP, so these patients should be having a CPAP titration, which should be done in the sleep laboratory. So there only will be able to come to know, because AHI is not going to give us an answer, because AHI is going to be normal in these patients. So a CPAP can be used in these patients, but my choice in majority of the patients will be to take an opinion from a ENT colleague and then treat them as much as possible, because many of these patients, they may be, younger age groups, lean and thin females. So those patients are not very well compliant with their CPAP immediately.
Sure. That's very well taken. But Mavi, the problem is finding an ENT surgeon in India who does all this, because majority of the ENT surgeons are not interested in this. Mandibular advancement devices in India are a huge failure, because they need to be really, made according to the dimensions, the anatomy of a particular patient. And the issue is, there is no one in India who does that. There are a few centers I know in Mumbai who work with that, but it is out of reach of majority of the people. So, a lot of companies have come up with these devices. For example, ResMed now has a mode in the CPAP device, which is the ShePAP, or, her device, wherein it is classically, they're promoting it for classic sleep apnea in females, because even in females who have the classic sleep apnea, who are obese, the compliance with CPAP is much less as compared to their male counterparts. And this becomes even more difficult in people with upper airway resistance syndrome. So what this kind of a special CPAP does is, it kind of picks up in which phase of, it splits the expiration into multiple phases. And accordingly, it would kind of titrate the pressure which is given to the patient during the exhalation, right? So it's not a single pressure during one expiratory cycle which is given to the patient. It is kind of broken down into multiple pieces, and this is said to be more comfortable by these females who have the upper airway resistance syndrome. So this is still work under process, but I think to sum it up, we need to pick it up. We need to, because a lot of these females would be shunting between psychiatrists, psychologists, they would be given cognitive behavior therapy, but would still have tiredness, lethargy, and you need to think about UARS to actually pick it up and start treating it. All right. So changing gears, we'll come back to it again because we've already got more than 100 questions right now. I really don't know how we're going to finish this, but changing gears, because central sleep apnea is something which is very important, not only for practicing pulmonologists, for PG students who are here. It's a long question, so you really need to prepare it, So Bindu ma'am, any classification, a quick classification of central sleep apneas, and what exactly is this central sleep apnea? What's so central about the central sleep apnea?
Central sleep apnea is a sleep-related disorder where you have a diminished or a cessation of the effort to breathe. And it's usually due to the generation of the impulses in the pontomedullary area. And the classification broadly is primary and secondary. The secondary is usually due to a cause. It could be common, it is heart failure. It could be other medical disorders like kidney disease, structural deformities like kyphoscoliosis, amyotrophic lateral sclerosis, drugs like opioids, which can cause CNS depression. There are plenty of causes there. There's a classification which Dr. Modi had given. One is central sleep apnea with chain strokes breathing. He said where there is crescendo, decrescendo type of pattern. The second one is central sleep apnea with medical conditions where there is no chain strokes breathing. Next is hyperventilation periodic breathing, where when you sleep above altitudes of 11,000 feet, you have hyperventilation and apnea. And the next one is those associated with medications, especially opioids. And the final one is treatment emergent CSA, where you have an OSA patient on CPAP. He could develop something called a complex CPAP. So those are the secondary. It is heterogeneous, but you need to identify the cause or the classification, because treatment goes in that pattern. And where you don't find out the cause, it is a primary.
Absolutely. Point well taken. So, Swapnil, I'll put this to you. This is a difficult question. So everyone, when you talk about central sleep apnea, everyone wants to talk about plant gain, loop gain, and the interaction between these two. So any words of wisdom on that? Are they really important to pick up, or central sleep apnea is just like, treat the heart failure and 90% of central sleep apnea is covered? So ma'am has already talked about, something about the pathophysiology. Anything that you want to add to that, Swapnil?
Yes, sir. So mainly, as you said, more than 80% are because of in our practice are because of secondary to cardiac heart failure, secondary to congestive heart failure. But there are other disorders also which can lead to central sleep apnea. Briefly, if we see about how carbon dioxide fluctuation affects it. So usually these are the fluctuations or oscillations in carbon dioxide levels. They affect the respiratory center. So in what happens in heart failure related central sleep apnea, the fluctuations in PaCO2 around the apneic threshold. There is something known as apneic threshold. So the CO2 level below which the breathing stops or causes hyperventilation if it's above that. It causes cyclic breathing patterns. So when PaCO2 falls below that threshold, it leads to hyperventilation and breathing. When it falls below that threshold due to hyperventilation, then breathing temporarily ceases until CO2 rises again, which again triggers respiration. So these fluctuations happens because of PaCO2 levels. There are certain things related to chemosensitivity of the peripheral receptors also. So especially with CCF patients, they often have increased sensitivity to CO2 at peripheral and central chemoreceptors. So this increased response leads to exaggerated ventilatory responses, promoting instability and again periodic breathing. There is something known as circulatory delay. In heart failure patients, delayed circulation time between the lungs and brainstem chemoreceptors contributes to the mismatch of feedback control, which worsens the oscillatory breathing pattern. So all these things can cause or are there in etiopathogenesis of the central sleep apnea.
Thanks for summing it up so well. It's most of the times it's the hearts or the peripheral musculature which is not working hard enough to put the signals to the brain, and that is summing it up. That's exactly what the pathophysiology is. So I'll come to Unnati, ma'am. So one of my patients, ma'am, very severe sleep apnea, was treated with a CPAP device. And once the treatment was started with the CPAP device, their wakefulness or their respiratory distress during night actually worsened. And when we repeated the sleep study, we saw that after starting the CPAP, the patient actually now has got a lot of central sleep apneas. So why has the CPAP precipitated these central sleep apneas? What is this term, treatment emergent sleep apnea, central sleep apnea, and what should we do about it?
So treatment emergent central sleep apneas has been, as you said, in the ICSD third classification, the text revision, which has come in 2023, has said that you have a patient whom you are treating for an obstructive sleep apnea. You treat the patient and you see either treatment emergent or treatment worsening central sleep apneas, an AHI more than 5 for the CSA, central sleep apnea, and these should be the predominant or more than 50% of the apneas on your titrate or the CPAP titration PSG. Now, they have added in 2023 that your patient should be symptomatic also. Symptoms in the form of sleepiness, symptoms in the form of, unrefreshed sleep or, waking up in between. Initiation or maintenance of sleep is an issue. You wake up with witness apnea. So all sleep related symptoms. Okay. So if you have at least one symptom and if you have a CSA or a treat therapy emergent central sleep apnea, then this is treatment emergent sleep apnea. The most important thing to do in 80% of the patients is to wait and watch. However, some of them, 20% of them they will have symptoms. They will not be, compliant to PAP therapy or CPAP therapy, and then adaptive servo ventilation and other modalities may be tried.
Sure, ma'am. And also, a very important point for the PGs here is once in DNB respiratory medicine, a long question came, which was mixed apneas. And people did not know what mixed apneas was. So mixed apnea is the other name of treatment emergent sleep apneas. So if you get that, please don't write a fancy answer. It's just treatment emergent sleep apneas, right? So I'll come to Prajay. So, one of the reasons of central sleep apnea is, of course, heart failure. And that is what 80-70% of all the sleep apneas that we see. But then, you have these fancy terms like the Ondine's curse, or wherein there is a central chemoreceptor hyposensitivity. Do we ever see this in clinical practice? And your thoughts on that, Prajay?
So this Ondine's curse is actually as a myth word which is used. It's used in Germany. It's used because of it was a curse given to his unfaithful husband that he should not be able to sleep in the night. And I would say I was when asleep.
No, it was a wife.
Unfaithful husband.
Come on, man, it was the wife.
The curse was given by the wife to the husband. So in this, and I would say I was lucky to see this first child which came to our department, in the NAR department, and I'm very thankful to my senior madam, Dr. Joshi madam, who was the HOD that time. We had seen this case of Ondine's curse. So she was a young girl, roughly around 5 years, and she came with a complaint that she was not able to sleep in the night. So the problem, this Ondine's curse is nothing but it's called congenital central hypoventilation syndrome. What we are saying that CSA, that central sleep apnea, it's actually the hypoventilation variety, what Modi sir was telling, that hypercapnic variety, but it is since birth and is a very rare genetic disorder. There is a gene which has been found out that is called the phobiobox gene, which produces a protein FOX2B, is a transcriptor factor, and the main problem is there is the not proper development of the autonomic central nervous system, which regulates the brain activity for the breathing part, and because of which they are not able to breathe in the night because there is a poor perception of the brain for the changes in the carbon dioxide levels in the body.
Sure. So this is something that you would see, every now and then, and especially, if you work with legends like Professor Joshi, you would see them more often. She was my fellowship examiner, and I still, get tachycardia listening to that name. Much love to ma'am. So coming back to Bindu ma'am. So ma'am, how does one start the treatment of a central sleep apnea? It is just Lasix and CPAP, or is there more science to it?
Yes, treatment need to be individualized because it's a heterogeneous condition where different etiologies contribute to the central sleep apnea. One thing you can easily do is lifestyle modification, which includes avoiding alcohol, take a proper drug history, avoid sedatives, drugs which tend to suppress your central nervous system, healthy sleeping habits, those need to be, and of course, maintaining the body weight. So that is a lifestyle adjustment. And the commonest cause, as we have all been saying, it's cardiac failure. So treatment of cardiac failure. And then, of course, the treatment is CPAP. You need to give a positive airway pressure. And in the patients who have hypercapnia, bi-level BiPAP can be given. And ASV is also a mode of ventilation which can be given. Supplemental oxygen therapy is next, especially in those with high altitude periodic central sleep apnea. A novel therapy has come up, phrenic nerve stimulation. I think it will be discussed. And medications, 2 drugs have been said. Acetazolamide induces metabolic acidosis, which will stimulate the respiratory center. And theophylline also is said to be a respiratory, helps in stimulating the respiratory center. So those are the things which is being said.
Absolutely. So the crux would be, increasing or decreasing the time that the blood takes to go to the brain. So heart failure has to be treated. And of course, then you need to stimulate the respiratory center if the respiratory center is depressed. So that can be done either with acetazolamide or with hormones or with theophylline. So there is mild data. There's very little data regarding all this, but it does exist. So in the right patient who does not have heart failure, the acetazolamide or progesterone may be tried. Very little data with that, but it does exist. So Swapnil, ma'am was talking about this phrenic nerve stimulation. You talk about it every.
Can't hear you.
And then, but no one knows where this is. It does exist, but my question to you is, where does it exist? Where is it?
Frankly speaking, I have never seen or never used it. So I just know that it is not a very recent one, but approved some 8-9 years back. It is an implantable phrenic nerve stimulation device. It is usually placed transvenously. It stimulates phrenic nerve, leading to diaphragm contraction and regular breathing during the sleep. It actually detects the respiratory signals via its thoracic leads, which are placed near the phrenic nerve, and it stimulates to restore normal respiratory rhythm. It works independently. Unlike CPAP and BiPAP, it works independently of the patient's respiratory effort. It's particularly used in central sleep apneas in patients with heart failure who usually do not respond to CPAP or which are intolerant to CPAP. In such cases, it can be used. Obviously, not a first.
So it is. Yeah, it's available. So I know of a patient, young army general who met an accident, and the cervical spine and the cervical vertebra had gone for a toss. And this guy was dependent on a tracheostomy for his breathing, and he was on the T modes all the time for his breathing. So in this patient, out of compassion, someone got it from the US. So the device would cost somewhere between 28-30 lakhs. And the system that is required to run it was actually not available at that time. But because of the compassionate grounds, and we got it for this guy, but very difficult to get your hands on this. But for the postgraduates, the younger people who are here who will be giving their exams, this somehow is a favorite question, though no one has seen it, but you will be asked about it, right? So prepare that. So another favorite question, another favorite topic that no one has ever seen in life, but everyone talks about is adaptive servo ventilation. And everyone, talks about ASV as if that is their best friend. No one has ever seen it. So Unnati ma'am, what is this ASV? Where is this available? And when should a pulmonologist be using it for central sleep apnea, if at all?
So adaptive servo ventilation, simply put, is a form of a ventilation or a closed loop breathing. So basically you are cycling. It's like a ventilator which is flow, or what do you say, a volume cycled with a preset pressure. So you have a pack, and with that you are giving a breath. Now, exactly how it works is basically in the CSA, it is said that you have a hypoventilation followed by hyperventilation. So a preset pressure will help you with your, whatever the PAP therapy. However, whenever there is a hypoventilation followed by hyperventilation, this cycle is cut by giving, as soon as the machine understands that there is a hypoventilation in the background, it's like an apnea that it understands, and it will help you give a volume cycled or a flow cycled breath, and this will prevent hyperventilation, and this will prevent your episodes of hypo and hyperventilation. Frankly speaking, even I have not used AVS device, though they are available in the market.
None of us have, but we need to. Yeah, so it's always been there, but we don't know what to do about it, and that's correct, and that's what the data also shows. So Mahavir, to diagnose a central sleep apnea, does one always need a sleep study? Is there a way out? Can you diagnose or can you label a central sleep apnea without doing a sleep study? And for this, do you need a in-lab titrated sleep study, or a home sleep study would be okay for it?
Yeah, so it's a good question basically because it all depends upon the kind of sleep study what you're doing. I mean, your lead placement and your technician needs to be very well trained. But basically, central sleep apnea one has to suspect, because most of the central sleep apnea what we see in our clinical practice are those which are related in your heart failure patients. So if you have a patient who's having heart failure, or then maybe a post-stroke patient, maybe 2 to 3 weeks after stroke, and then it may remain there for maybe 4 to 6 weeks more, and then they can respond spontaneously. Or you have a patient who's on chronically on hemodialysis, so those kind of patients. So basically you have to suspect, and sometimes patients those who have gone to high altitude, or those patients, especially we have chemotherapy patients where we keep on giving them opioids and we don't remember or we don't realize that they are the patient those who are becoming drowsy, dull in the daytime because of central sleep apneas which are happening because of their opioids. So those kind of drug history is also very, very important. Or if you have a patient those who have underlying neuromuscular disorder, like recently I had patient of ALS, and then she was not able to sleep at night, was having a lot of daytime drowsiness. So those kind of patients are obesity hypoventilation patient. So those patients, those who can develop central sleep apnea, of course you need not level 1 sleep test for all of them. Maybe even in your level 2 and level 3 also you will be able to, because you basically just want to know that there is cessation of flow and there is no respiratory effort. So even your level 2 as well as level 3 study will be able to diagnose this kind of central sleep apnea. So to diagnose them, I think the AHI should be more than 5, and out of your total respiratory events, more than 50% should be having central sleep apnea component. And another important component is then to diagnose if they have this crescendo decrescendo kind of pattern, like what we see in typical in CSA CSB. So over there you will need, I think, a good kind of sleep lab to diagnose these kind of patients. And especially if you have a patient who has hypoventilation and you want to know their transcutaneous CO2 level throughout night, then you will need a level 1 kind of. So you can diagnose CSA on your level 2, level 3, but you to know the etiology exactly, and if your clinical picture is not clear, then you will need a level 1 sleep study in these patients.
Very well said. And another point there always is that, home-based sleep studies for patients with suspected sleep apnea, obstructive sleep apnea only. Patients who do not have fulminant or overt heart failure, other comorbidities which are uncontrolled, these patients should not be subjected to a home-based sleep study, simply because when you start titrating these patients with CPAP, these patients go into REM sleep, because they've not been going into REM for a long time, because they've always been awake because of their sleep apnea, central or obstructive. They go into very deep REM sleep, and this leads to CPAP induced, deep REM, which leads to hypoventilation and decrease in their oxygen saturation further. So, you don't want an accident with a sleep technician at home wherein a CPAP has been given to a patient and at 4 a.m. the patient stops breathing. So any patient with suspected sleep apnea, which is non-obstructive, where there are a lot of comorbidities, the important message to give to the postgraduates here today is that ideally it should be a in-lab, attended study always, right? Because you might land up in soup sometimes. So it's changing gears again from central sleep apnea. We'll come back to it. But obesity, hypoventilation, Prajay, is something that as pulmonologists, we should never miss out. It is something that we very often see. What are the diagnostic criteria for picking up obesity hypoventilation syndrome? And is a sleep study always required to pick up obesity hypoventilation syndrome?
For obesity hypoventilation syndrome, the diagnostic criteria are very clear. The BMI has to be more than equal to 30 kilogram per meter square. The daytime carbon dioxide level, the partial pressure of carbon dioxide has to be more than 45. And there should be no other cause to cause the rise in PCO. Like a person should not have any airway disease or neuromuscular diseases, COPD, asthma. And the third, as you said, why the sleep study is important. The sleep study is important because there are different types within the subtypes within the OHS, which as Modi sir was selling, as 90% of the patients have an OSA and some patients have hypoventilation, which you will be able to diagnose or identify only on the basis of the sleep study, depending on their flow limitations and the desaturations, which will help in further differentiating the treatment parts. Because if a patient has predominantly OSA component, then these patients are very well going to be managed and responding to your CPAP. And the other kind of a patient might need a BiPAP or an NIV. Hello.
Sure, very well said. So, Mahavir, what's the problem with obstructive sleep apnea? What does obesity actually do, which adds fuel to fire to the sleep apnea? What's the pathophysiology behind it?
Yeah, actually, as Prajay also said that majority of these patients, they will basically have only obstructive sleep apnea, and only few patients, they will have hypoventilation. And these are two different category of patients. So what obesity basically does is that there is a lot of fat in the trunk as well as in the lower chest wall, because of which there is a decrease in the diaphragm movement, plus there will be decrease in their expiratory reserve volume. So this all causes increase in the increase in the resistance of the lower airways, and because of which there is definitely more and more respiratory muscle load. And to combat with this respiratory muscle load, or to increase the work of breathing, what is done is that definitely at sleep there has to be more respiratory drive. And this increased respiratory drive, if the patient is not able to fulfill, especially because of their diaphragm is weakened in the REM sleep, because diaphragm is the only muscle which is active in the REM sleep. All other muscles, they are gone into complete atonia. But in obesity, because this diaphragm also has decreased functioning, there is microatelectasis. So these patients, then they get predisposed to hypoventilation because of the CO2 retention. And these frequent episodes of these CO2 retentions during REM sleep, it will then overshadow, and then the patients will have daytime symptoms of this obesity hypoventilation syndrome. So I think there are two patients. One, those who have this predominantly OSA, they are the one, those, and the other mechanisms like maybe the fluid shift in the obese patients. So they will have a lot of venous engorgement. There will be increased pulmonary capillary wedge pressure, and then there will be overstimulation of this. So all those things also come into play. So it is not only the obesity, but the fluid shift and the other diaphragmatic pathophysiology that all come into play, and that can add into this OHS component.
So lots of factors that we really don't know. There are theories with hormones, with leptin sensitivity, with insulin sensitivity. So there are a lot of things that we really don't know. But yes, so I'll ask Bindu ma'am regarding that. So ma'am, what are the clinical features of obesity hypoventilation syndrome? It is just a fat guy with sleep apnea, or there is something more to it?
The name is explanatory. It is obesity, hypoventilation. So BMI is more than 30. And hypoventilation, the sign is there is no tachypnea. It is respiratory rate is shallow respiration. So I'll split it into three. And these people tend to have hypercarbia, awake hypercarbia. The findings of hypercapnia and hypoxia is also there. When the patient is in hypoxia, the symptom is you have breathlessness, sort of an air hunger is there. And the first sign of hypoxia is tachycardia, heart rate more than 100. Your respiratory rate is more than 20. Your accessory muscles are acting, strap muscles are acting, intercostal indrawing. And when there is severe hypoxia, cyanosis is there. Now coming to hypercarbia, The symptom is headache is there. You could have severe warm extremities, bounding pulse, and those are the signs of hypercarbia. And if the patient goes in for corpulmonale, you have the obvious signs of elevated JVP, hepatomegaly, pedal edema. So the signs, clinical signs, can be classified based on those features which are there: hypoxia, hypercarbia, and features of corpulmonale.
Sure, ma'am. And, a lot of people are asking about the comorbidities that are there with obesity, hypoventilation syndrome. And are there any peripheral, signs, how you pick it up? So I'll take this with Swapnil. Swapnil, any signs on the ABG, any lab tests, or how would you pick up obesity, hypoventilation in someone who is suspected of having sleep apnea? So anything on the ABG there or anything in the lab tests that would tell you, or any of the other comorbidities which would point you towards the diagnosis of obesity, hypoventilation?
Yeah. So basically, two things we can look. Those can raise suspicion of OHS based on ABG. First is, as we discussed, partial pressure of carbon dioxide more than 45, daytime hypercapnia, and the second, bicarbonate levels of more than 27. It's a very good screening test. Bicarb of more than 27 denotes chronic hypoventilation. So these two things are the most important things to look for in the ABG. Apart from those, these two, there are some other signs. With simple lab investigations, we can get polycythemia. So polycythemia is another thing which will increase the suspicion of OHS in a patient who is having characteristic features of OHS. And other things like pulmonary hypertension, or pulmonary right heart failure, metabolic syndrome. These are the things which are comorbidities associated with OHS and which we can pick up on OPD basis.
Sure. Unnati ma'am, a very controversial question. I don't agree with, this is just a personal bias. A lot of people, or when you read the guidelines, they say that majority of the people with obesity, hypoventilation do patients this. So in your clinical practice, how do you start the treatment of a patient with obesity, hypoventilation syndrome? Do you start upfront with a bilevel NIV, or do you give them a CPAP device first? If they fail on a CPAP, start them on an NIV. I'll ask you two questions. What does the evidence say? And hand on your heart, what is your clinical practice?
Okay. So the evidence says that both are equal. Okay. So whether it is PAP therapy or it is NIV, however, in practice, we can go in this way. If I have a patient who was presented to my outpatient department where it was a OSA suspected, and then subsequently I have found out it's obese and has come as OHS, yes, PAP therapy may be tried. However, when I have a patient who is admitted in an exacerbation in a type 2 failure, and where I have treated the patient successfully with NIV, then probably NIV will be the treatment of choice, or bilevel PAP will be the treatment of choice. Again, in OHS, it is said that lifestyle modification is very important. It is easier said, written than done. It may be initiated and probably done by a patient who was hospitalized, very seriously ill, and is gone better, but difficult to sustain. Herein probably the newer things, like bariatric surgery, the newer drugs which are working against obesity probably have some hope in future. We don't have evidence as of date. However, this will help patients probably to take care of that obesity component, and then probably you and me will not have to debate about the therapy devices.
Oh, ma'am, because I think, the problem with these devices is the data says that you can use a CPAP, but the problem is in India, nothing is insurance backed. So in these guidelines have been made for the US, wherein you can start the patient on a CPAP. If the patient fails the CPAP, the insurance company is going to swap it with a bilevel device. This is not going to happen in our country. If the patient has bought a CPAP device and then you tell him after 2 weeks that, boss, this is not working, you need to buy. So, these things don't work in India. So we really need to be careful, especially when you are interpreting the sleep guidelines, these American Sleep Association guidelines. In India, please always take them with a pinch of salt, because these guidelines have been written keeping insurance in mind. In India, sleep is totally out of the purview of insurance. So everything you do as per the ASM guidelines really need to be tweaked in the Indian practice. So, Prajay, this is for you. Bindu Madam had very nicely said that, ask the patient not to have alcohol. By that's not fair, no? And how many people would not have alcohol when you tell them not to have alcohol, lose weight? Someone who has obesity hypoventilation syndrome. Now, these are guys who are super obese. These are guys who are breathless, going to the washroom. And very nicely, in our OPDs, we tell them to lose weight. कि ऐसे नहीं होगा, weight कम करो, तब तक ठीक नहीं होगा. So how do they lose weight? What are these non-pharmacological devices? Unnati ma'am has already said that we don't have a lot of data right now on drugs like semaglutide or the newer ones, the GLP analogs that are coming up. But what can one do practically? What are the non-pharmacological management strategies in patients with obesity, hypoventilation? Just asking them to lose weight, just asking them to stop drinking alcohol. I really don't think that works in clinical practice.
First
So,
thing,
Prajay,
when
any
we are
takes
saying
on that?
non-pharmacological treatments, so one thing, when we also say patient, if you start losing weight, your machine pressures might go down, or they are in the hope that my machine will go out if my weight is getting reduced. But now I just want to pinpoint certain things. It's like when we are saying OHS, it needs a multidisciplinary approach, because OHS is not just a sleep-related breathing disorder. It is also sometimes associated with metabolic syndrome. Person has diabetes, person has blood pressure. So when we are saying about the non-pharmacological part, it will not only take care of OHS, but it will also take care of the other comorbidities. It will help in proper control of your sugars, proper control of your blood pressure. Weight loss will help not for completely eradicate your OHS, but it will help in as a supplementary or as an adjunctive therapy. It will help in, might be helping in reducing the pressures. Because when you start using the CPAP machines, what you have to tell your patient that first you start using this machine. Because with that, their daytime fatigue, their daytime somnolence will get decreased, and their ability to exercise will increase. And this is how we can able to reduce the weight loss. And regarding, as you said about the alcohol, see, you cannot completely tell them to stop completely. Once in a blue moon, they might have it, I would say. But we have to tell them that these are the things which can trigger or which can exaggerate your obstructive sleep apnea and OHS. And there are high chances that time you might go into much more respiratory depression. So when you give them the scientific reason for it, then they know how much amount of alcohol they have to take. You cannot completely stop. At least a small quarter might not cause them that much respiratory depression.
So you probably don't have Punjabi patients, and so you don't deal with that. We do, and it's very difficult. But very rightly said that you really need to talk about you need to tell them why this is important, and this is what will probably convince them. So Mahavir, coming to you, acute exacerbation of obesity hypoventilation syndrome, or the overlap syndrome, which is combination of sleep apnea with COPD. And I think this is one of the commonest things that we see as pulmonologists in our emergencies. A lot of our physician colleagues, would still give them uninhibited oxygen, nebulizing them with 12 liters of oxygen. And then these patients become absolutely drowsy in the emergency. And a lot of them get intubated or land up in the ICU because of, silly things that we do in the emergency. So how do you manage an acute exacerbation of OHS? I think this is so important, and this is much more tricky than managing a simple acute exacerbation of COPD. And, I would want a more detailed answer in this. What would be your NIV settings in an acute exacerbation of obesity hypoventilation syndrome? How would you tweak the pharmacotherapy in these patients? Because this is something which is so mismanaged.
Yeah, absolutely right. Because I think in my presentation also I said that OHS is basically diagnosed in 75% of the times when they come in the acute crisis. So they are the those who will be landed up in the casualty, and they have typical this type 2 respiratory failure. And clinically looking at them, they are definitely obese, they have CO2 retention. And most of the times, we have to basically manage these patients, as you said, that not with very high oxygen, but a controlled oxygen therapy. And the NIV is something which is very important in this category of patients, because you have to treat their hypoventilation and not the plain CPAP. So normally what I tend to do is I start them with a bilevel device, maybe an IPAP and EPAP. And it's very important for us to know that EPAP is basically just to open up their airway. So it is to depending upon their snoring, depending upon their apnea events, and that is not possible in the emergency, but also the oxygenation, because the EPAP or is similar to your PEEP, what you use in your mechanical ventilation. So this is basically for the alveolar recruitment. So increase your EPAP levels. Maybe I start normally EPAP of around 6, and then you can increase it by 2 depending upon their snoring, plus depending upon their oxygen levels. And IPAP normally I start with maybe say somewhere around 16. So 16 and 6, keeping a pressure support of around 10. Look at how much is the tidal volume, and we can actually calculate the tidal volume depending upon the patient's ideal weight, and there are different formulas for which we can come to know how much should the patient's ideal body weight. But say maybe around 500 tidal volume is something which we need to give for these patients, because many of these are actually obese patients. So increase their IPAP depending upon their chest wall expansion, depending upon how much is their alveolar ventilation. And you have to always consider that the dead space also something which needs to be considered in these patients, and CO2 levels based upon this. And never immediately go on the CO2 levels. As I saw, normally, in the ICUs, what happens that in 2 hours they will do CO2, and if CO2 is not coming down, they will like to ventilate the patient. But these patients, they always take time. In my presentation also, I said that in home management also, you review these patients periodically, maybe give 4 to 6 weeks period of time, and slowly they will improve over a period of time. So I think to manage these patients of obesity hypoventilation, you don't require these patients to give steroids. We basically need, maybe many of them, they are in cor pulmonale and they have fluid retention, so give some diuretics to these patients, controlled oxygen and NIV. If you have a patient who is known to you who has COPD component, then maybe steroids and then bronchodilators, those kind of therapies. If they're coming to infective exacerbation, then antibiotics. But NIV is something which is very important. Then there are inspiratory time and how much should be the eye time in these patients. So normally we have to have a backup rate, and backup rate is something which is supposed depending upon the patient's spontaneous respiratory rate. If it is 20, keep around 2 to 3 breaths lesser than that as the backup rate. And suppose the patient's spontaneous respiratory rate is 20, you keep 18 or 17 as the patient's mandatory rate. And then you can decide the TI, the inspiratory time. So 60 is the total seconds in which your 17 breaths are to be delivered. So 60 divided by 17, that becomes your cycle time for one respiratory cycle. You have a patient who has this restrictive kind of defect with OHS. So over here, 40% of that one respiratory cycle can be your TI. If you have a patient who has obstructive pathology or who has a diaphragmatic weakness, then you keep them as a 30% of this as your TI. So these are certain settings. Even the rise time also, if you have a patient who has a restrictive, then you keep the rise time as low as possible. And in obstructive, you give more of a rise time so that the patients will be more into the inspiratory phase. So there are some of the other settings which we can do in these patients, but I think more is IPAP and EPAP and the controlled oxygen therapy.
Absolutely. I think you've summed it up so well. And giving them controlled oxygen is something which is very important. And we're talking about obesity hypoventilation, which is where then supposedly the lungs are healthy. But a lot of these patients, who have the overlap syndrome, wherein there is COPD associated with sleep apnea, that is actually a ruling out criteria for obesity hypoventilation syndrome, because for definition of OHS, the lungs need to be absolutely normal. But we do get to see overlaps, in clinical practice. And a lot of our physician friends would be scared of giving them high intensity NIV, saying that it is COPD and the lung is going to rupture if you give them high intensity NIV. It's exactly the other way around. High intensity NIV is very useful in these patients, and a pressure support, which is, Mahavir was saying 16.6, wherein that's an amazing, rate or a kind of way of ventilating the patients where the pressure support is very high. And it's actually the pressure support which is going to decide how well ventilated this patient is. And with someone who has such a stiff chest wall with obesity hypoventilation, so giving them a decent pressure support, something like 10 is what is going to make all the difference in these patients. So don't shy away from giving them a high IPAP, don't shy away from giving them a decent EPAP, and decongest them right at the beginning. And this is going to be really useful for this, right? So I'll start the...
Just one addition. For these patients, we keep pressure support up to 20. And in OSA patients, normally pressure support of 10. So that is the rule which I normally use in my patients, that, keep pressure support even up to 20. And high intensity NIV is something which is a better word for all of this, yes.
Absolutely. And don't be scared of hypoxia. The problem is these patients have been living at a saturation of 80% for the last few years. It is your resident or your nurse who will be scared of that 80% and give them the oxygen, which is actually going to make things worse. So don't be scared of hypoxia. These patients are used to hypoxia. There's absolutely no fun in giving them, high FiO2. This is going to make only things make worse. So I'll start with the panel questions. We've got close to more than 160 questions now. I am going to not obviously be able to do all of them, and I apologize in advance if I'm not able to take your questions. So a lot of these questions are repetitions. Some have already been answered, so I'll take the ones that have not been answered. So I'll start with Prajay. Prajay, so obesity hypoventilation syndrome, the basic pretext is obesity. So if a patient comes and says, and he tells me that, Sejal, who's a pulmonary physiotherapist from Maharashtra, is asking this, that if a patient says that I'm going to go back to my normal, BMI, I'm going to be Hrithik Roshan in a few days. So is my OHS going away for good, or will a component of obesity hypoventilation remain even if I lose the weight?
As I said before also, okay, OHS, when we say to reduce weight, normally it doesn't go off. It's like with the weight loss, it might be 20 to 30% your sleep-related breathing disorder might get reduced. But if you say that is why the gold standard treatment is the CPAP and not the weight loss is the gold standard, because it's not going to completely eradicate or eliminate it. It is a supplementary or an adjunctive therapy with your PAP.
Sure. So I tell my patients that data says that even if you come to your normal BMI, if you have obesity hypoventilation syndrome, there's only a 10% chance that you might actually not have OHS despite achieving your target weight, which is going to be impossible in 99% of Indian patients. They are not going to come back to a BMI of 20, 21, 22 when they come to you with a BMI of 45. So it's easier said than done. So I'll come back to Unnati ma'am because this is a question on ASV. So ASV, this is by Dr. Dhaval Bhadra, who is a pulmonologist at Maharashtra, and sir says that ASV has actually been found to increase mortality in certain subset of patients with central sleep apnea. So what are these patients and when should you give ASV?
So this was a study basically done in patients with heart failure, and when they realized that wherever they had a higher mortality. However, retrospectively, when they studied, they found that it was found in patients who had a EF less than 45%. So that is why ASV is contraindicated, as Mahavir sir said in his presentation, not to be given in patients who have a heart failure and an EF where it is less than 45%. Now, this just could be contributory because, post hoc analysis has said that the patients in that group which had a lower EF were more sick and were more prone to mortality. However, there have been those two studies, Advent and the other one, which says that you have higher mortality, and that's why ASV, if you have a lower EF, not to use an ASV.
Sure, summed it up really well. So Mahavir, next one is for you. You've got your fan following, dude. We've got a lot of comments where people are congratulating for you. Either these are true comments or these are your PG students. So anyways, so Mahavir, someone has asked, what is the role of esophageal pressure monitoring in upper airway resistance? I knew this was coming. So what's your take on that?
So basically, I mean, there are centers, especially in Japan, where the people are doing this esophageal monitoring, manometry monitoring, and because arousal is something which is actually been decided, the best way to diagnose an arousal is by doing a esophageal manometry kind of thing. Okay, because the intrathoracic, and nowadays it has been found out that it is not the deflections in the EEG, but more accurate way of diagnosing the arousal is if there is a deflection in your esophageal manometer. So one of the ways by which you will be able to diagnose UARS more commonly as compared to even your EEG pattern of arousal. So I think that is one of the ways, because there are different mechanisms. So many times the flow limitation may not be always followed by the arousal. There are certain mechanisms where there is a cortical arousal and there is autonomic arousal. So cortical arousal is something which you will be able to find out on your EEG, but the autonomic arousals are not, which can be found out on your EEG. So those kind of arousals where the negative intrathoracic pressure deflections, they can be found out by doing this esophageal. I think that is what Arjun can clarify it better, but
so that's the gold standard, and you very rightly said a lot of these, because by defining upper airway resistance syndrome, these are not classic sleep apneic patients. So they have a lower threshold of apnea, they have a lower threshold, they get up again and again, but the problem is this kind of awakening might not be picked up by an EEG, and that is why you need this change in the esophageal pressure. So one of my juniors, who was a very notorious person, was given a thesis topic on this, because they were notorious. And they were given a sample size of 50 patients. And, we could not even do a single patient, because every time you put in someone who's sleeping, you put in something through their nose, and half the people would get up at that time. Or if you put something, if you put a pressure transducer, it's not practical. So I don't know how the Japanese are so innocent, docile, and how they sleep with things up their nose. Indian patients don't take it. So this is very important for vivas and final exams, but practicality, I really don't understand how this ever happens. So Bindu ma'am, this question is been answered partially, but I see it's been asking again and again. So how would you pick up upper airway resistance syndrome in clinical practice? And is this not just mild OSA? Why so much of halla about it? Why can't you just treat these patients? Why do you need a special name for this upper airway resistance syndrome?
Yes, it's a milder form of OSA, and the sleep studies show that the hypopnea index is less than 5 per hour. And what is more significant here is the respiratory effort related arousals. You need to have an arousal more than 10 seconds, or the arousal index of 10 per hour should be there. So that is the thing which you need to pick up in the polysomnograph.
Sure. So it's important to pick it up. So it's not just another, of course, it's a variant. It's there in the umbrella, the spectrum of sleep disorder breathing. It is there.
There is no desaturation. The SaO2 need to be more than 92.
Sure, because I think it is very important to pick up this disease, because there is very impressive data which says that more than 90% of people who actually suffer from upper airway resistance syndrome do not know that they have a sleep disordered breathing. Okay. These people would go to physicians, they would go to psychiatrists, they would go to orthopedics people for their, leg pains, they would go to a gastroenterologist for so-called irritable bowel syndrome, but they would not know that they've actually got a sleep disordered breathing. And no one would suspect sleep apnea in a woman who has a BMI of 18 or 19, right? So if a patient who comes to you with a non-specific constellation of symptoms, and in these symptoms, normally, a lot of these anxious patients would have insomnia. But if a patient who's anxious, who has these somatic complaints, and on top of that, the patient says it's a female patient most of the time, and they are sleepy during the daytime, these are the patients you need to screen for upper airway resistance syndrome. And that is the importance why this term upper airway resistance syndrome is important, because this is a treatable cause of these so-called somatic complaints. You can actually help these patients by doing, something for them. All right. So next question, yeah, please, Mahavir.
Yeah, only one of the difference between mild OSA and this UARS is because in mild OSA there will be intermittent hypoxemia, and we know that this is chronic intermittent hypoxemia, which is basically related and causing more of cardiovascular morbidity and metabolic syndrome in patients. However, in patients with UARS, because they don't have desaturation, actually they should not be having more cardiovascular morbidity and mortality. But it has been said that even in patients with UARS, because of the different arousals, frequent arousals, and these frequent arousals causing sleep fragmentation, and it causes the ventilatory instability. And this ventilatory instability over a period of time can cause these patients to develop even cardiovascular mortality. So practically they both can be treated on the same grounds, although the difference of desaturation and hypoxemia, the pathophysiology may be a bit different. And many of these UARS patients over a period of time, they can convert into OSA.
True point, very well taken. So I'll take the next question. This is by Dr. Jaideep Singh from Ludhiana. How do you distinguish between primary central sleep apnea and treatment emergent sleep apneas in a diagnostic setup? So you need to compare the sleep study. So I've done the sleep study for a guy wherein there is only pure obstructive sleep apneas. I've started this patient on a CPAP, and rather than making his life more comfortable, I have made his life more miserable. So in minority of these patients, I would subject them to a repeat polysomnography. And in this polysomnography, which I am now doing after the patient is on CPAP, I see the emergence of central sleep apneas, which were not there in the pre-CPAP polysomnography. I would label that as a treatment emergent sleep apnea. However, practicality of this is very difficult. A lot of these, getting a sleep study for one time in India is difficult enough. So getting it done twice is more of a theoretical possibility, but that is how you would do it, right? So I'll go to Prajay now. So Dr. Amrita Bose from Mumbai is asking, how do you, this is very important, and this is actually very interesting, how do you ensure accurate diagnosis of patients when they are presenting with overlapping features of obstructive sleep apnea, central sleep apnea, obesity, hypoventilation syndrome, because none of them are mutually exclusive. You can have a really obese guy wherein there is an element of obesity hypoventilation syndrome. Because of their obesity, they have diastolic heart failure or associated systolic heart failure, which is leading to central sleep apnea. And of course, majority of the obesity hypoventilation syndromes will have obstructive sleep apnea. So is it important to actually pinpoint these differentials? And how would you start treating this? Difficult, but what would you do?
Ideally, it is difficult to pinpoint each and everything. But as rightly said, if a person is anything coming to with a cardiac failure, I would not like to do a sleep study at the upfront. First, I would like to optimize the patient with the diuretics, whatever optimized nebulizations. I will try to treat the airway disease and then go ahead with the sleep study. That is why my dictum is I always do a sleep study before the time of discharge when my patient is almost stabilized, and that will give me a true picture how much is the component of the central apneas, how much is the component of the obstructive sleep apnea. And that time also I would also come to know what is this daytime PCO2 levels, because sometimes the daytime PCO2 levels at the time of admission can have been jumped up because of the exacerbation. So on that first reading of that ABG, which is showing up a high PCO2 due to exacerbation, you cannot label just a patient of an OHS.
Sure. So a lot of time these patients will have these overlaps and you might not be able to pick up, but the good part is that majority of them will respond to the CPAP device. Of course, if clinically you see there's an element of heart failure, you obviously treat the heart failure. You would not be dependent on a sleep study to pick up the central sleep apnea and then start treating these patients with diuretics. I think a lot of these patients who come to us with fluid overload, who are obese, by default in the emergencies would get a shot of Lasix,
Yes.
and we would probably be doing their echoes more than doing their sleep studies, right? So we would probably pick this up and kind of treat this. So Mahavir, the next one is for you. This is a theoretical question, but I think a lot of PGs here would be listening to us. So this is from Dr. Ajay Kumar Srivastava, who's from Gorakhpur. And he says, in a polysomnography, how do you distinguish a obstructive event from a central event?
Yeah, so in both of them, the cessation of the airflow will be, the amplitude will be less than, 90% flow limitation will be there. And in the obstructive event, definitely there will be presence of respiratory effort. So in the thoracic and abdominal belt, there will be presence of the respiratory effort, whereas in central apnea, there will be no effort. So that is how I think we will be able to diagnose both of them based upon their PSG pattern. And we have to then calculate that if the patient has a predominantly central apnea, then the AHI should be more than 5 and 50% of the respiratory events should be central as compared to in obstructive apnea where the majority of the events are obstructive. So I think that is how.
So I think you need to train yourself in PSGs, and just looking at the epoch sometimes would tell you whether these are central events or whether they're, tough. So I think this question we've answered this, but I think this question is coming up again and again. And so 3 questions in succession are on the treatment of upper airway resistance syndrome. So I think I'll answer this once and for all, that upper airway resistance syndrome, the treatment is difficult. There is some data on cognitive behavior therapy. There is some data on CPAP therapy in these patients. There is some emerging data which says that when you try to treat females with upper airway resistance syndrome with the classic nasal mask, these patients might not be able to tolerate this. So there is very little data now which has come up with nasal pillows. So the gentler the device or the interface with which you treat these patients, the more susceptible these people would be to therapy. So a practical take would be, if there are associated somatic issues, if there is associated anxiety, depression, treat it. These patients can be sent for CBT, cognitive behavior therapy. We are scared of using these fancy terms in clinics, but this is something which helps a lot of our patients. We have data on COPD and smoking cessation with CBT, very good results. So don't be shy of sending these patients for CBT. CPAP can be tried in these patients. There is data which tells us that 97% of these patients, when they're given a CPAP device, are not going to stick to it. There's in fact data which tells you that in the first OPD visit after a CPAP has been given to a patient with upper airway resistance syndrome, 70% of them would not use it beyond their first OPD visit.
Yeah.
So it is a difficult proposition to treat. There are no definitive criteria in the Western population wherein the mandibular advancement devices are available, which can be counter-made to the needs of a particular patient. They would probably use the mandibular advancement devices. Unfortunately, in our country, it's all theoretical, and we don't, kind of use them. Bindu ma'am, should every obese patient be screened for obesity hypoventilation syndrome? Or is there a criteria or is there a clinical threshold where people should be screened for obesity hypoventilation syndrome?
The issue with obesity hypoventilation is that when there is hypoventilation due to multiple causes, it could be leptin or the limitation of diaphragm movement. There is hypercarbia. The carbon dioxide level in the morning hours is more than 45. So it is that part that is causing the symptom. And of course, there is chronic hypoxia, which is So a person more than 30 BMI with symptoms of headache, daytime somnolence can get a blood test where you can look for your bicarbonate level and the ABG, where the PCO2 can be monitored, and we can screen it for the early detection and prevention of complications of OHS.
Sure. So it would be overkill to actually screen every obese guy for obesity hypoventilation. Even the most deserving ones who have classic or most frank obesity hypoventilation syndrome in India, we are not able to do their sleep studies. So I think if you're in Switzerland, Denmark, probably yes, but in India, it doesn't happen that way, unfortunately. So this is for Unnati ma'am. This is by Dr. Ajit Kulkarni. Sir has asked that, if a patient is suspected sleep apnea or sleep disordered breathing, classically the Epworth score is high and the patient has classical features of sleep disordered breathing. But you do a sleep study, but the AHI comes out to be normal. So what do you do with these patients next?
So again, confirm your history and your scores. So it is said that if you do not have comorbidities and if you get a high pretest probability score, your sleep study should come positive. Go for a level 1 PSG, which would help you pick up the variants like a UARS. Okay, and sometimes it may be just that I often have residents who say I have a sleepy snorer and the chap is doing a night duty. So it's like, look for things other than OSA which can cause sleepiness and which can cause snoring. Yes, a sleepy snorer should be evaluated in detail for OSA, obstructive sleep apnea. The gold standard is polysomnography, a level 1 PSG when your, probably a home-based study is inconclusive. And look for, as we've been taught by JMJ madam, the sleep diary. The sleepiness, the sleep hygiene. What is the issue which is causing the sleepiness and what is the issue which is causing the snoring?
Sure, very well taken. That's so important. Everyone who's sleepy does not have sleep apnea. There can be multiple issues and you always need to think about that. A very important point that Dr. Nivedita Kumar, madam, is a dental sleep medicine specialist. We need more of you in India, ma'am. She says that people who have got UARS will have associated craniofacial structural deficiencies, a high sympathetic drive, and a dental consultation is necessary to evaluate these patients for procedures like palatal expansion and myofunctional therapy. Point very well taken, ma'am. I think we as pulmonologists need to kind of, especially in this subset of patients, do more dental referrals and ENT referrals, provided our dental and ENT colleagues are interested in this part of therapy and if they are able to help us. Sure. Looking forward to doing that.
I can add, we have a dental college with us, which does a lot of work in Mumbai on basically, these mandibular devices. They do their own PSG, and it is probably one of the institutes, in the dental institutes who work on, probably, sleep apneas and, probably the dentist way of tackling it.
Very important. And we often as pulmonologists, because you become so myopic in doing what you want to do, you kind of don't ask for help. So it is always good to ask for help, and point very well taken, right? So Prajay, I'll ask you this. This is from Dr. Anil Kumar, who's a pulmonologist from Tamil Nadu. And is there, someone who has a central sleep apnea and you're not sure about how to treat it and probably the patient is not accepting a CPAP device, can you just treat them with the nocturnal oxygen alone? Because one of the problems here is hypoxia, because of the increased circulatory time, the problem is hypoxia. So is there some data which tells you that you can actually treat these patients with oxygen alone at night?
So as Modi sir was explaining, there were two categories. One, they were with hypercapnic central sleep apnea, and one which were with normocapnic central sleep apnea patients. So in this normocapnic, or where the carbon dioxide levels, or if you know the partial pressure of carbon dioxide levels are normal, and if they're not tolerating PAP therapies, you can give nocturnal oxygen to avoid the hypoxemia too, because that hypoxemia itself can cause pulmonary vasoconstriction and finally can lead to a cor pulmonale kind of a condition. But if your carbon dioxide levels are higher, then just giving an oxygen, you will trying to correct the hypoxemia, which is actually a drive for the respiration, and you might further exacerbate your PCO2 levels.
Sure. That's very well taken. All right.
Can I add? There are small studies which have shown benefit of nocturnal oxygen 1 to 3 liters low flow oxygen in normocapnic patients in reducing severity of the AHI and symptoms also. But long-term benefit is not proven, and it does not improve the mortality rate, and also does not improve LV function as such. So it's not.
So you would probably not do it.
So here I would like to just add one more thing. So there are now orofacial masks which are available, because most of the time what we have seen, people are not compliant or not feeling good because of that pressure, because of on the nasal bridge. So now the Philips has a mask which is like this kind of this, and which can avoid the complications which can occur because of the nasal bridge and the headache which occurs.
So I have shifted to those masks completely. So in our unit, we've kind of, even in acute exacerbation settings, we've shifted to those masks, or the whole face or the Goli mask makes a lot of difference. And thankfully the difference is 1,000 rupees. So not much, but yes, if the patient can afford it, one would really go with that.
They can actually read books and papers while using that BiPAP or.
Sure. So Swapnil, this is for you. Dr. Jayakishan has asked this. He has a patient who is morbid obesity. The AHI is really high, and this guy desaturates to 70% when he's sleeping, and his daytime saturation average is around 90%. So how do you manage this patient from a sleep point of view? Do you start him upfront on a bilevel NIV?
I think so, yes. With such high levels of carbon dioxide levels during daytime, I would upfront start him on bilevel PAP instead of CPAP. Obviously, after managing all the comorbidities and optimizing all the other factors. Yes.
Sure, absolutely. So someone who has high CO2 levels, someone who's obese, probably might not do very well on a CPAP alone, right? So this is again a question which is coming up again and again. I'll try to answer this. This is by Dr. Simon. And he's asked that when should you start an IVAPS or an AVAPS? Now, you need to understand the basics of NIV to answer this. The most basic NIV that came into practice when NIVs were launched was the S mode. Now, what is the S mode of NIV? S mode of NIV is when the patient is taking, breaths at their own leisure. But the problem with the S mode is if the patient is hypoventilating, someone who has a carbon dioxide of 100 plus, someone who's breathing at a respiratory rate of 8 or 6 per minute, if you give them an S mode, it is not going to be sufficient because S is spontaneous, right? Because the patient is hypoventilating. So what they did was they added T to the S, which was the ST mode, in which a time fixed, breath delivery was given to these patients, that not just a spontaneous mode. After a certain fixed amount of time, the patient would be given a breath by the ventilator device. Unfortunately, a lot of these patients don't do well even if the ST mode is given to them, because their tidal volume, which is given by whatever settings that you've used, is not adequate, especially in patients who have a very thick chest wall with severe obesity hypoventilation syndrome. In these patients, you need to give them a fixed tidal volume, which will ensure that the patient is ventilating well. So an AVAPS or an IVAPS is nothing. It is just an extension of the ST mode, wherein there is an algorithm which is inside the machine, which senses what is the tidal volume which is being generated by the patient when a fixed pressure and a fixed time is given to these patients. So what the machine would do is the machine would sense if that particular tidal volume is picked up or not, and the pressures and the time would be adjusted by the machine. So it's just an intelligent or a smart way of the machine working. Different companies would have their different names for it. So when would you use an AVAPS or an IVAPS? If the patient has been given an ST mode, and despite the ST mode, the patient is not generating adequate tidal volumes. Or upfront, if my patient has come to me with an acute exacerbation of obesity hypoventilation syndrome, severe overlap syndrome, where the patient is drowsy and I want to hook on the patient to an NIV, upfront I would use the AVAPS or the IVAPS mode in these patients. So someone has asked about jaw exercises, whether they help. Would anyone want to take that? Because I really don't know if any jaw exercises can be prescribed to people who have upper airway resistance syndrome or any kind of sleep disordered breathing.
Yeah, so Arjun, I mean, maybe there is a role of this myofunctional therapy. So there is this myofascial therapy is something which is can be used to train your muscles. And if you go online, there are a lot of these, you know, there are some kind of exercises like to do the jaw movements and the tongue movements, the thrust movement. So those kind of movements where you can just improve the muscle tone. So that can be, I think that can be the answer for this. But not like it can be used for someone who is just not able to tolerate any other kind of therapy and is not a candidate for surgery also, and plus want to go only with the lifestyle modification kind of thing. So myofascial therapies can be, myofunctional therapies in these patients can be used.
And this is the problem in sleep. You can't exercise during sleep. So the thing has to be in the sleep stage. So that is, it's like it has to be active. So as Sir said, the exercises might help you, in the neuromuscular control, but, it would not help because the patient will be sleeping and not be able to exercise in that stage.
Sure, that's a point very well taken. Mahavir, again, there are 3 people praising your talk. But someone has said that Dr. Arjun is very handsome, so I take the cake, right? So it's fine. You can have your good talk there. So Bindu ma'am, this is for you. Yeah. So Bindu ma'am, someone has asked if someone has upper airway resistance syndrome, and if you don't treat it, will it become frank sleep apnea?
Yes. It's in a spectrum between snoring and your mild OSA. So if you don't treat the UARS, it will become a OSA.
So, right. So it can, of course, because if other risk factors come into being, if these patients gain weight, they're going to probably develop sleep apnea. The next question is very important, and this is by Dr. Ramesh, who is an ENT surgeon from Aurangabad. He says, why is compliance lesser in women, and can you increase it? No, you cannot, my dear friend. You cannot do that. And Mahavir, Prajay, and Swapnil, all of us will swear to that. You cannot do that. Unnati ma'am and Bindu ma'am, can you please tell us why we can't do that? Any of you?
So again, it is all about counseling and understanding and making the patient realize. So like if I have a patient who, to give an example, had severe sleep apnea and was unfortunately diagnosed to have severe depression, was on multiple drugs, and the psychiatrist realized, no, this is a young patient, is fitting in a profile of obstructive sleep apnea, and I need to evaluate these patients. Prajay and Swapnil will understand what I am relating to. So then, probably this patient today, after 10 years of being on PAP therapy, has realized that no, PAP therapy has made me go down on my medications, has made my life more easier. I'm working more well. So it's all about talking and, tailoring it to what the patient, how to counsel the patient. This would have been a probably non-compliant patient, but it's like showing the patient, see, with PAP therapy, this is what is done. You had, a probably concern on your medications. The medications have gone down. You are doing well in life. You are, in fact, working well in life. So it's like, it's a tailor-made approach. You have to make the patient realize whether a man or a woman. I can give examples of men who will say, "Hum nahi vaprega." Understood? On this side on the western side of India. So we have to just break the stigma where, it is available. So the first thing that I do in my practice, since I deal in a public hospital, I have to really work hard to get the CPAP arranged, to the trust and all. They are not affording patients. The first thing that probably Dr. Bindu will also agree to, we do is, how did you feel with the PAP therapy and will you use it? Once we have an agreement, it's like, will you stop? Are you ready to quit smoking? So are you ready to use the device? And then we start further ahead with other things in the background and mobilization for the PAP therapy.
Yes,
So
just
yeah.
the patient's experience will tell him. You give him a trial and the person will know how effective it is in relieving the symptoms.
Sure, I was expecting a spicier answer, but I would be in trouble if I go there. So I would not go there. I restrained
Anybody
yes,
has experience of using those gender-specific algorithms for the management of sleep apnea, RestMed or Philips? That you said.
AirSense her.
AirSense her.
I've just started using it, given it to one of my patients. So my experience is exactly one. So I don't know any of the other panelists.
But how that one patient is doing?
Okay, like it's difficult to treat women with sleep apnea. It is, because she's the classical phenotype of sleep apnea, wherein the female is obese, is going to be okay to treat. The problem comes in patients, even in male patients who are not obese. The thin sleep apneics are always difficult to treat, and the thin female sleep apneics, Madam very rightly said, I think there's always a psychological element to it, that they don't want to be sleeping with a device, and it kind of has a mental setback there, that a woman should not probably be using a device. It's considered unwomanly. And also there is data which tells us that the loop plant gains and these cycles, there is data which tells us that actually when females are given a expiratory pressure, because of the friability, because of the less overall muscular strength of the upper airway, the pressure tolerance of the upper airway in females is much lesser than males. So you really need to, in the older days when the classic CPAP devices were available, we used to have things like A flexing, B flexing, C flexing. And what these flexings would do is that they would split the expiratory pressure into different parts. So C flexing was one of the modes that was tried by Philips Respironics many years back, and they said that this C flexing is going to ease out the expiratory pressure and it is going to divide it into multiple parts, and probably females would be using it more often than. But none of this has stood the test of time ever. Apart from the use of a humidifier and the use of ramp when you are starting a patient on a CPAP device, none of these so-called comfort features, including flexing, A flexing, B flexing, C flexing, a heated humidifier wire in the CPAP device, have never stood the test of time. So whether or not this her sense and all these things would make sense, I think only time would tell all of us, because it has just been launched. So it's still work under progress. We really don't know how this would work. So
Another
it is
thing
already.
I will just like to add is because many of the times these females, they will present more of insomnia and those kind of symptoms. So it is very difficult for you to label them as obstructive sleep apnea just based upon their history and clinical features, because they have more of this insomnia. And why to deny, but it is more of a social stigma. That's what the females are treated that way in many part of our society. So we have to accept that, still, it is been seen that a female who's using a CPAP will definitely be treated differently as compared to a man.
All right.
Arjun sir, I would like to add one more thing as with the non-pharmacological part. So considering everything and treating everything, we should also take care of the sleep hygiene part. What time they are sleeping, what time they are getting adequate sleep is there or not. Just giving a CPAP and if a person is sleeping at 1 o'clock, 2 o'clock, it's not going to make sense. So that part needs to be taken very well.
Sure. People are asking again and again about pharmacotherapy of respiratory stimulants. I think it is beyond today's, but in obesity hypoventilation syndrome, we have already talked about acetazolamide. Only in dire, desperate settings you can use that. And there is some data on progestins which can be used in certain subset of patients to improve the respiratory drive. But as of now, they are not the standard of care. And for all patients, for all practical purposes, whatever respiratory stimulants are used would be in dire circumstances if nothing else works, because there is not a lot of robust data which is supporting their use. Are there any Indian specific guidelines for the management of non-OSA sleep disorders? We do have a white paper on sleep disordered breathing from the Indian Society of Indian Sleep Disorders Association by Professor J.C. Suri. A lot of it is the Indian modification of the ASM criteria, wherein we've talked about what is to be done in Indian settings. Unfortunately, that is more to do with obstructive sleep apnea. So no, we don't have an Indian white paper or guidelines on UARS or obesity hypoventilation syndrome, right? Um, a lot of these questions are getting repeated. So it is already 10:36. So I'll take last two questions. And the first one I'll put to you, Mahavir. In patients with suspected upper airway resistance syndrome, any advantage of doing an upper airway CT scan for these patients? Any morphometries or doing an MRI scans of the upper airway? Is this going to help?
Yeah, sometimes I mean the patients, they mostly will have some clinical manifestation. If they are symptomatic with some nasal or maybe some throat symptoms, then I think it makes sense of using it. Somebody who has a clear-cut retrognathia or some other anatomical defect. So in these patients, you can some may consider sending them to a maxillofacial surgeon, and over there, I think the role of this 3D reconstruction of the doing CT scan and MRIs of the skull, that can be useful. But otherwise, I think mostly clinically we should be able to judge that. Yeah.
So a lot of these people only, children, wherein you need to do some kind of a surgery, a UP3 surgery, or a pre-surgical workup is required. You can do it in those patients. Uh, a lot of these questions are getting repeated. People are asking a lot of questions on sleep apnea. So we are not discussing sleep apnea today. So cardiovascular risk factors and complications of sleep apnea, I don't think how to use modafinil in clinical practice. So these are a lot of questions which are associated with sleep apnea. So any parting comments? I'll ask with Bindu ma'am. So any parting comments?
The three important parts we have discussed today. One is UARS. UARS is significant. There is a significant proportion of people which goes underdiagnosed. And as Dr. Arjun has put it, they end up with psychiatrists, fibromyalgia with orthopedicians. So the symptom of upper airway resistance syndrome may be wide and varied. So we need to detect with the polysomnography. And the obesity hypoventilation syndrome, those with BMI more than 30 with presenting with morning headache, daytime somnolence, disturbed sleep, can get a screening of blood test and see if the carbon dioxide level is more than 45, and that can be done. And central sleep apnea, of course, it is related to a lot of secondary conditions. So the management of central sleep apnea is varied and it has to be individualized.
Sure, ma'am. Mahavir.
Yeah, I think I feel we all should be able to diagnose at least OHS, because that is something which we are all seeing in our clinical practice, but we tend to treat them as COPD patients, looking at their serum bicarb levels and try to have the equipments which can monitor this nighttime PSCO2 levels by using a transcutaneous CO2. So that is how we can advance our practice into sleep medicine. And even diagnosing central sleep apnea and those kind of disorders. But most important is obstructive sleep apnea, even in a heart failure patient also. Although we are trying and we are thinking that this patient might be having central sleep apnea, they have so many other comorbidities. Even in these patients also, obstructive sleep apnea is something which is seen much more commonly as compared to central sleep apnea. So treatment emergent central sleep apnea, these opioid induced, these are all there, but let us not forget the majority are still obstructive sleep apnea.
Unnati ma'am, are these important long questions for kids who are listening to us today?
Yeah, and I want to tell the kids that There are some things we can't manage. Take care, take your psychiatrist in, coordination, your ENT surgeons in coordination. Our center also does drug-induced sleep endoscopies. The ENT guys, they have a thesis on it. Take the dentists for help. Okay, you cannot manage everything and anything. That's how we are taught in our center. Take it as, a multidisciplinary approach when it comes to the sleep SRBDs or SDBs, whatever.
And ma'am, especially if it's a female patient?
I will disagree. I'll try and talk to the patient. Okay. We are a headstrong female dominant department. So talk it out. Yes, you will be able to get. And yeah, one more thing is the AirSense Her or the devices that you use. They are very fancy, beautiful, and that is one of the things which can, make female patients probably take the machines in a better way. Something that looks good, seems good, appears good, feels good. Okay. I may not have that leisure with my patients, but yes, those who have that liberty, definitely.
Thank you, ma'am.
Pink color, I guess.
Oh, pink color.
Yeah.
Swapnil, are you there? Can't see you.
Yes, I'm there.
Yeah. So any parting comments on obesity hypoventilation syndrome?
Yes, so just diagnosis of OHS is not enough. We have to manage other comorbidities. We have to see the compliance of the therapy, and we have to understand the phenotype and the basic underlying pathology of the comorbidity of the patient, which are he or she is suffering from. As Unnati madam rightly said, adequate counseling at the beginning of the therapy is very much important. Repeated follow-ups regarding the mask fitting is very much important if we are prescribing PAP therapies. And so basically it's a combination of all the things.
So Prajay, last one comment from you is a pulmonologist supposed to know all this. Are we okay with 90% of the practice, which is sleep apnea? So the 10% or less than 10% is so much of hard work required to treat these 10% patients?
Definitely. So now 2-3 things as the parting message you want to know. So as now most of the machines are with cloud based. So like how we give reminders or a receptionist give reminders to the patients every month that your appointment is there or once in 3 months. So this data from the cloud can tell us whether actually our patients are using the machine properly or they are not using the machine properly. And you can give a feedback to the patients via the receptionist or whoever the team member is there that you are not using the machine, there is some leakage, that your apneas are not getting corrected, and this is how you can work on it. And you should always make a rule that apneas, whether it's OSA, whether it's OHS, whether it's central sleep apnea, anything, the treatment is not just PAP therapy. It's a multidisciplinary approach. You should have a weight reduction, regular exercise, dietary. You have to take the care of the other comorbidities. Then only you'll be able to successfully treat apneas and your patient will be compliant with the PAP therapy.
Sure. All right. So thanks everyone. It's already 10:45 and it's time to sleep now. So I thank Mahavir for his talk. So simple, so lucid, and summing it up so well. Yeah, 3 long topics summed up in 20 minutes. And for my fantastic panelists, thank you for being so, supportive, being so sportive, and for putting up with me. Always a pleasure interacting with everyone. And thank you, Team ICS, Amita ma'am, and all the rock stars at ICS for doing this, for helping our younger colleagues understanding these topics. No one talks about them. When we were residents, no one would probably, even talk about these things. And these things would come up as googlies in our exams. So not only are they clinically important, but for the younger colleagues who are listening to us today, prepare these questions. You will be asked these questions now or then. They are important, right? So thanks everyone. Have a good night and have a great day ahead. Thank you, everyone. Thanks.
Great, sir. Thank you very much.
Thank you.